Hello friends. So today we will discuss acute interstitial nephritis, a very important topic. We see patients of interstitial nephritis in our day-to-day practice. So it is very interesting, and we need to know few important points for acute interstitial nephritis. So today I will discuss this in detail. So there are two types of injury seen in kidney disease patient. One is glomerular and one is tubular interstitial. In glomerular and in tubular interstitial, there are different set of symptoms and different pattern of injuries depending on what we can identify the pattern. So there are some features like edema is more common with glomerular disease because of more proteinuria, and that is a little bit uncommon in tubular interstitial disease. Hypertension is relatively more common in glomerular disease and less common in tubular interstitial disease, as tubular interstitial compartment is associated with the concentration mechanism. So urine output usually preserved in tubular interstitial disease, and in glomerular disease because of less filtration, we usually see oliguria. And in urine microscopy, we usually get more proteinuria, and hematuria is also more common with glomerular disease, and these are less common in tubular interstitial disease. But leukocyturia is relatively more common with tubular interstitial type of pattern of injury. Coming to the definition of AIN, so AIN is acute, often reversible disease characterized by inflammatory infiltrate with edema of the interstitium. It is a pattern of injury that is usually associated with abrupt deterioration in the renal function, characterized by the increase in serum creatinine. Now coming to the incidence, so around 1% of all kidney biopsy during evaluation of hematuria and proteinuria is because of interstitial nephritis. Around 5 to 15% of the patients with unexplained AKI may have interstitial nephritis. Now coming to etiology, so some most important etiology is drug. Around 70 to 75% of acute interstitial nephritis is caused by drug. Among these, antibiotics are the most common cause, causing up to 30 to 50% of the cases. Then followed by infection, around 4 to 10% cases may be because of infection. Then some syndromic diagnosis like tubular interstitial nephritis with uveitis is seen in around 3 to 5% of the patients. And few systemic disease like sarcoidosis, lupus erythematosus, Sjogren syndrome, and many others may cause tubular interstitial involvement around 8 to 10% of the cases. Now coming to the pathogenesis. So it is a immunologically mediated hypersensitivity reaction to an antigen that is classically a drug or maybe an infection agent, more commonly a drug. So why we say that it is a type of hypersensitive reaction? Because we have few evidences like it occurs only in a small percentage of the individual, that we usually see in day-to-day practice, that hypersensitivity also develops in a very few set of patients. It is not dose dependent, so it is a type of idiosyncratic type of reaction, many times often associated with some external manifestation like some joint pain, some rashes. So it is a similar, we have similar to hypersensitivity reaction, and it reoccurs after accidental re-exposure of the same drug. So if we find that any particular drug is causing this type of injury, and if we use that drug again, that this type of nephritis again reoccurs. So it is pictorial presentation, so showing four types of injury pattern which can be seen with tubular interstitial nephritis. So one pattern is that the drug can bind to a normal component of the tubular basement membrane and itself act as an heptin. And the other pattern is the drug mimics an antigen that is normally present in the tubular basement membrane or the interstitium, and this induces a antibody mediated response. So against this antigen, the antibody mediated response occurs. The third pattern is that the drug itself can bind to the tubular basement membrane or deposit within the interstitium, and it may act as a planted or trapped antigen against which the antibody forms, and that ultimately leads to interstitial nephritis. The fourth pattern is that the drug can produce some antibodies and become deposited. So this immune complex gets deposited in the interstitium as a circulating immune complex. So these four types of injury can be seen in these types of patients. Now coming to the causes, so this is a big list showing many drugs responsible for the interstitial nephritis. So we can see that almost any drug can cause this type of injury. Among antibiotics, penicillin group like amoxicillin, ampicillin, carbapenicillin, methicillin, oxacillin, so they are all may cause interstitial nephritis. Then among cephalosporins, we can see that cefotaxime, ceftriaxone, and these are more commonly used drugs, so they may be associated with this type of injury. Then quinolones, ciplox, levoflox, moxiflox, and other quinolones may also cause interstitial nephritis. Then among antiviral agents like acyclovir, then few other antibiotics like cotrimoxazole, clarithromycin, then ethambutol, and gentamicin, indinavir. So interferon, nitrofurantoin, rifampin, teicoplanin, vancomycin. So I highlighted the more important drugs which are more commonly used in day-to-day practice. Among NSAIDs, both COX-1 and COX-2 inhibitors can be associated with interstitial nephritis. Then many anti-epileptic drugs like phenytoin, valproate. Then among diuretics, chlorthalidone, and this furosemide and indapamide. So they all may cause interstitial nephritis. Then PPIs are a very important group of drug, lansoprazole, omeprazole, along with H2 receptor blocker like cimetidine, ranitidine, famotidine. They all may be associated with interstitial nephritis. Then other drugs like azathioprine, allopurinol, diltiazem, warfarin, and so on, propranolol. These may lead to this type of injury. Now, what can be the presentation? So, as we already discussed in the pattern of injury, that it is basically associated with non-allergic type of injury, and few symptoms may be there, like vague symptoms like nausea, decreased appetite, anorexia, and it is basically a subacute type of kidney injury settling over a period of 1 to 2 weeks, and manifested by rise in serum creatinine, and so we should suspect the diagnosis of interstitial nephritis if somebody has developed progressive rise of serum creatinine over a period of 1 to 2 weeks. So it is usually non-oliguric, develops within 3 weeks after starting the inciting drug, and rapid improvement in the renal function can be seen after stopping the inciting agent, and it does generally confirms the diagnosis. When patient present with non-specific symptom, as I already told, anorexia, chills, flank pain, myalgia, arthralgia may be sometimes seen. Now coming to the triad of the interstitial nephritis, in up to 10% of the cases, these all three symptoms like fever, rash, and eosinophilia can be seen. So this is a classical triad of interstitial nephritis. The negative side of this is that only 10% of the cases present with all the three symptoms. And individually, if we talk about the fever can be seen in 30%, around 50 to 100% patient of penicillin derivatives like methicillin may be associated with fever, and it is usually absent in the AIN caused by NSAIDs and non-beta lactam. So fever is particularly associated with the methicillin group of drugs. Now coming to the rash, rash most commonly associated with sulfonamide, allopurinol, phenytoin because of hypersensitivity reaction. And among beta lactam, if you talk about particularly beta lactam, around 2% of the beta lactam may be associated with AIN, and it increases to 15%, which is the drug is used for more than 2 weeks. As I already told that the triad seen in 40% of the patients, microscopic hematuria can be seen in 50% of the patient, and most patients will, of having AIN due to these drugs may recover after stopping the drug. Now coming to NSAID-induced AIN. So the symptom and the pattern differs a little bit from that which is caused by beta-lactam. Here we can see that eosinophilia is seen in around 40%. Extrarenal symptom is only 10%. Pyuria can be seen in 40 to 45%. Microscopic hematuria only 5 to 10%. Then hematuria, frank hematuria can be seen in around 35%. Hypertension is around 20 to 25%, and edema is more common because of associated proteinuria, so that can be seen in around 70% of the patients. So it is most commonly because of hemodynamically mediated AKI, and it is not usually accompanied by the triad like fever, rash, and eosinophilia are less common, and it may occur over a period of 3 to 18 months, so the lag period is quite long. Now coming to more importantly used anti-tubercular drug rifampin, and it is also a very important cause of AIN, and we usually see that if the patient receives intermittent type of dosing of rifampin like thrice a week, then it is more commonly associated with AIN. Here Because of antibody formation, the AKI occur more commonly with after the re-administration of the drug. So if somebody has used rifampin in the past and which is restarted, then this type of injury is seen more commonly, and it is mediated because of antigen antibody complex. Now coming to PPIs, so PPIs are very commonly used in day-to-day practice, and we should be aware that these drugs are not also very safe. So we should be a bit cautious before using this drug as a routine, because first case was reported in 2004, and the mean duration of exposure before the this pattern develops is 3 months. And hypersensitivity syndrome is seen only in 10% of the patients. So more of the time, it is an indolent type of course, usually not picked up early, so need to be careful. And we can see that among all causes around antibiotics may cause around 35% of the patient of AIN, followed by the PPI. So PPI is a very important cause of AIN, responsible in around 10% of the patients. Then NSAID is around 7%, and autoimmune sarcoidosis can be seen in around 9%, Tino syndrome 4%, IgG4 related disease in 2%. And similarly, infectious agent can be seen in bacterial 4%, viral 2%, 1% of the fungal infection may be associated with interstitial nephritis. Then few malignancy may be associated with interstitial nephritis. So typical presentations are fatigue, malaise, anorexia, and weakness. Only consistent clinical feature is AKI is only consistent feature, but oliguria is less common. Around 70 to 85% patients recover partially or completely after stopping the drug. Among urine analysis, as we already discussed, that proteinuria is less common, only 1 to 2 plus proteinuria can be seen. Microscopic hematuria is more common, seen in 30% of the cases of drug-induced AIN, and more common with certain other antibiotic group of drug like methicillin-mediated AIN is more commonly associated with hematuria. And gross hematuria is commonly seen with NSAIDs. Then leukocyturia is universally present in all cases of methicillin-induced AIN, and it is present in less than 50% cases with other form of drug-induced AIN. Now coming to eosinophiluria. So eosinophiluria means eosinophil in urine is a common feature of drug-induced AIN. It is positive in around 1% of the urinary. If the 1% of the urinary white cells are eosinophil, it is known as eosinophiluria. The problem with this test is that its sensitivity is not very high, only 67%, and specificity is around 73%. Other causes of eosinophiluria are cystitis, pyelonephritis, and acute tubular necrosis. So this is a diagrammatic representation of drug-induced AIM. So we can see that beta-lactam antibiotics and NSAIDs, they all induce cell-mediated immunity that may lead to systemic features like fever, rash, and eosinophilia. And at the level of kidney, they may cause interstitial edema, macrophage and T lymphocyte infiltration, and ultimately leads to decreased glomerular filtration and WBC and RBC cast in urine, and also associated with eosinophilia. Now, coming to the indication of kidney biopsy, as I told earlier that it is most of the time a clinical diagnosis if we are not getting any other etiology for the renal dysfunction occurring over a period of days to weeks. We can say that it may be AIN, but to confirm the diagnosis, the kidney biopsy is needed. And there are a few other points favoring the indication of kidney biopsy, like patients who are being considered for treatment with steroid for acute interstitial nephritis. So before starting the therapy, we can go for biopsy to get what we call diagnosis confirmed. Presumed drug-induced AIN, which don't have spontaneous recovery after stopping the drug. So most of the time, the recovery occurs after stopping the drug. But if the patient persistent to have kidney injury and our diagnosis is not confirmed, we can go for the biopsy. And if some atypical features are present, like high-grade proteinuria, that will cause a diagnosis of AIN uncertain, then we can go for biopsy to prove our diagnosis. Now coming to natural history, so what happens if we don't treat, and how the AIN behaves? So most patients recover fully or partially if AIN recognized early and the culprit agent like drug is promptly withdrawn. So in antibiotic like methicillin mediated AIN, around 90% recovery can be seen, and in non-methicillin mediated group, around 40 to 50% cases may show recovery. Severity of renal failure is not linked with the prognosis. So if somebody even requiring dialysis may recover from the interstitial injury if the drug is withdrawn at early stage. What can be the poor prognostic factor? So there are some biopsy features which can suggest the poor prognosis, like presence of diffuse macrophage rich infiltrate in biopsy, interstitial granuloma, tubular atrophy means there is already chronicity has set in, severity of interstitial fibrosis, and those caused by the NSAIDs are also having a poor prognosis. And if the duration of AKI is more than 2 weeks, it is also associated with poor prognosis. Now coming to the treatment part, so glucocorticoid is commonly used, and 1 mg per kg per day dose, maximum 60 milligram of the steroid is given for minimum 1 to 2 weeks, and beginning to a gradual taper after the serum creatinine has returned to near baseline. For the total duration of the therapy is 1 to 2 months. Most patient improves within 1 to 2 weeks. In patient is having more severe acute renal dysfunction, therapy may be started with the IV methylprednisolone for 3 doses like zero point 0.5 to 1 gram per day for 3 days, then followed by oral therapy. Other immunosuppressants have also been tried in steroid dependent and steroid toxicity cases. So few case reports are with cyclosporin and cyclophosphamide. Although very strong evidence are lacking, they can be used who don't respond in 2 week therapy with steroid, and therapy for longer than 4 to 6 weeks is not indicated. So take home message is that avoid indiscriminate use of drug whenever possible, as we have seen that even PPIs are not safe. So we should judiciously use these drugs, prescribe medication for a limited duration or as per the indication, and choose safer alternative whenever possible. Thank you so much.